Hi, this is Brian Kim. I'm going to share with you case number 47 in the best way to do cataract surgery series. This is a patient who is a high myope. This is a very big pupil, deep chamber. This is an average lens density. I'm going to show you systematic lens disassembly techniques using double chop, cross chop, mechanical fracturing. These high myopes also tend to have real stretchy zonules, and so as I'm trying to spin the lens here, you can see I'm going to have a stuck lens fragment. I'm going to show you how to re-hydrodissect the lens piece up. So I'm using a cotton tip to help center the eye. I'm using a corneal marker to help me center and size my rhexis. I'm making my paracentesis incisions first superiorly on the right side and then on the left side. You can see the blade is flat to the iris plane, which creates a nice corneal shelf, which will allow me to have a good self-sealing corneal incision. I'm injecting some intracameral lidocaine and then some intracameral dispersive viscoelastic. You can see I'm putting in a lot of viscoelastic because this is a deep chamber, big pupil. Do my triplanar corneal incision, make a vertical groove, and then place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me with the cannula, and then enter. I'm using the cannula to help control the eye as I do the triplanar corneal incision. I place the forceps into the incision, and this is my puncture style capsular rhexis. I puncture in the central, pull downward towards me, trying to make sure I have a good controlled sized rhexis, which will help match the corneal marks that I made before. Again, this is a big pupil, so you want to make sure you don't make the rhexis too large in this situation. I'm just trying to grab and re-grab every few clock hours, making sure I follow my corneal marks for a good, well-centered and sized rhexis. So finish off the rhexis, burp some viscoelastic out of the eye, and this is the capsular fornix hydrodissection technique. Place the cannula underneath the anterior capsule on the contralateral side, decompress on the left side, place the cannula under the right side, hooking the lens and then spinning the lens. You can see the lens spins quite nicely here. I'm going to irrigate the surface of the eye, making sure my sleeve is the appropriate length. And then I go in with the chopper to lift the incision, and then go in with the fingertip irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Place the chopper underneath the epinuclear ridge, out to the capsular equator. Turn the fingertip vertically, subincisionally, crushing the lens and bisecting it completely in half. This is the double chop maneuver, placing the chopper to the contralateral right heminucleus, pulling it centrally, crushing the right heminucleus in half against the fingertip. I place the chopper around the first quadrant and then crushing it with mechanical fracturing forces, using vacuum to pull each fragment up, crushing the lens pieces between the chopper and the fingertip into smaller pieces, and then emulsifying the lens pieces. Placing the chopper underneath the second quadrant, pulling it centrally, crushing it against the fingertip, bisecting that second quadrant into smaller fragments. And then again, placing the chopper out and hooking that last part of the second quadrant up out of the bag, and then crushing the lens piece between the chopper and the fingertip, and then emulsifying the lens piece. You can see here I'm trying to turn the second heminucleus around, but again, this is a high myope. They tend to have real stretchy and loose zonules. Rather than forcing the issue, I decided to just take the chopper out. I'm asking for my right-angled hydrodissection cannula, which the technician is getting ready. When I'm ready, I take the fingertip out and I'm pushing underneath the epinucleus. You can see I'm actually causing a separation wave around the epinucleus and the cortex. So I essentially performed a hydrodelineation wave by doing that maneuver. So I freed up the lens now. I lift the incision and place the phaco tip in atraumatically, and now I'm able to use vacuum to pull the heminucleus up, and I start to crush the lens piece in half with the chopper and the phaco tip. I'm breaking it into small pieces and emulsifying the small pieces, using again high vacuum to grab that heminucleus up, crushing it between the chopper and the phaco tip into smaller pieces, using mechanical fracturing forces to break up the pieces, and then emulsifying the lens piece. Grabbing the anterior aspect of the epinucleus now, and the epinucleus tumbles out quite nicely. I take the chopper out, push BSS with the cannula, take the phaco tip out, and then replace it with the INA. I'm starting to do the INA here. Again, with these high myops, you want to be very careful you don't pull on the capsular bag. They tend to have a little bit of a stretchy, weak type zonule, so you want to be very careful not to use too high vacuum when you're polishing underneath the anterior capsule. So I'm trying to make sure all the cortical material is removed from the capsular fornix all around 360. And I'm polishing also the anterior capsule edge. I'm removing some lens material off of the posterior capsule as well. Especially in the subincisional area. So once the bag is clean, I'm pushing BSS through the paracentesis into the subincisional capsular fornix, and lo and behold, you can see some lens material is liberated, and that was what I was going after when I was using the INA handpiece to remove the posterior capsule remnants. I knew there was some still left in the subincisional fornix. Now I'm pushing cohesive viscoelastic to fill the capsular bag as well as the anterior chamber. I'm going to sweep on the left side. Again, this is such a big eye, it takes a lot of viscoelastic to inflate the eye completely. Sweeping on the left side first, then sweeping on the right side. I'm going to inject the single piece acrylic intraocular lens into the capsular bag. I'm injecting the leading edge into the bag, but leaving the trailing side out. I go in with irrigation on, disengage each of the haptics off the optic, go underneath the optic, tilt it, and rotate it 90 degrees clockwise, making sure I'm evacuating all the viscoelastic from within the bag. Going underneath the anterior capsule edge because there can be some lens material mixed with viscoelastic in this area. Now I'm turning the lens so the haptics are in the more horizontal position. Now remove all the viscoelastic from the anterior chamber. Again, you can see there's quite a bit of viscoelastic in the anterior chamber and still coated on the corneal endothelium. That means all of my maneuvers were well away from the cornea because there was very little viscoelastic that was disrupted. There's still quite a bit of viscoelastic adherent to the corneal endothelium, which means there was very little motion and disruption of the viscoelastic near the cornea. I push BSS, with the cannula and then take the INA handpiece out, and then I hydrate my incisions. So again, this is a very big eye, big pupil, deep chamber, doing mechanical fracturing forces, double chop, cross chop. Again, these tend to have stretchy zonules, and you saw the second heminucleus wouldn't spin very well, even though I did spin it during the hydrodissection maneuver. But rather than perseverating, I use a right-angled cannula to actually hydrodelineate the lens off the capsule. I was able to tease it up out of the bag and disassemble the lens. So I hope this was helpful to you, and I thank you for your attention.